Alrighty. Good morning, and thank you everyone for attending our DUR board meeting. A few reminders for our meeting today. If you are dialing in via telephone, Google Meet has muted you. If you need to speak to the group, please press *6 on your phone to unmute and mute. We kindly ask that only those who are speaking to the group unmute the device via Google Meet. For the DUR board member, please preserve your question until the end of the presentation or ask in the Google Meet chat. For public comment, if you would like to provide public comment, a COI must be on file. Please send an email to medicaidpharmacy@utah.gov. Attendees that are not member of the DUR board, please enter your contact information in the Google Meet chat or send an email to medicaidpharmacy@utah.gov. Please use the chat on the right if needed. Please provide normative feedback after the meeting to help us improve our process moving forward. Thank you. And I don't see Dr. Eric Cannon is attending today at the moment, so I will chair until Dr. Cannon join our meeting. The first item on the agenda will be the review and approve of minute. Yes, Kuma?
So do you want to deal with approving the draft of the minutes?
Yes, do I have a motion to approve the draft of the minute? Did you make a motion to approve it, Kuma?
Yes, that's the motion.
Thank you.
The draft minutes.
Thank you. Do I have a second?
Second.
Thank you. All in favor?
Aye.
Aye.
Any opposed? Okay, motion passed to approve the minute. And the next item is the annual training from Tony Patterson, our Assistant Attorney General.
Thank you, Noon. This training is required by Utah law. I believe the primary purpose of it is to remind all public bodies that all state business must be done before the public. So with that purpose, we will jump in and cover the primary portions of the act as a reminder to those that have served on the board and as a refresher. So first of all, public notice must be given of each meeting. That public notice must include the date, time, place, and link when it is electronically. The meeting is electronic of the meeting, and it must include the agenda. The agenda is the controlling document for the board, for its meeting, for its discussion, and for decisions. Any items that are not included on the agenda may be discussed, but the board may not take action upon any of those items. It should be remembered that a meeting is any time there is a number of the board that have gathered, such as a quorum. There have been some discussion about whether or not that could occur without a quorum, but the statutory definition requires a quorum where the board or public body is acting or discussing upon a matter or receiving public comment. In light of that, it should always be remembered that when it comes to public comment, that we need to make sure that everyone has that fair opportunity, because all public comments are made part of the record, which must be provided on the Utah Public website. As part of that, it should be remembered by the board members that when they receive the packet, that is still confidential, that it has not been disseminated to the public and has not been converted from confidential to public. Once the board meeting is held, then it becomes a public document along with all the other public comments that must be part of the record for the board's activity. So I would just remind you to make sure that those not be disseminated. And of course, that makes sense. We want to have all entities that would like to comment on the state's business be on equal footing, be treated fairly, and have an opportunity to respond to comments that are provided. Now, one of the things that is important to remember during a meeting is that texting does not occur between board members. Now, some individuals believe that that would never be discovered, but of course, the Salt Lake School Board found out contrary. There was a reason to subpoena those records. Those became public, quite to the embarrassment of the board members, which led many to give apologies, and it created quite the uproar in the local community for a period of time. The same thing also happened to the former Attorney General, Mark Shurtleff. He thought that his personal device was something that could not be discovered and they would not find out what is on there. However, as part of the many investigations that occurred after he was no longer the Attorney General, he found out that they seized all of his personal computers, his phones, and they went through all of them as part of their investigations. Now, regardless of the fact that he was never convicted of a crime, he was never sanctioned by the Utah State Bar, all of his personal matters on his phone were reviewed by investigators. So just remember that texting is not done in public, that all public comments should be shared with all board members during a board meeting. Now, once the meeting has concluded, the recording of it, the minutes of it, both draft and finalized, must be published on the Utah Public website for review. There are circumstances when meetings may be closed. However, those circumstances, such as discussing a person's character, competence, or health, or pending litigation, really is not the subject matter that this board would discuss. Therefore, even though meetings may be closed, the nature of the work that is done by the board is not the nature of work for which a meeting would be closed. There may be emergency meetings, and I would work closely with the agency when those circumstances arose, if it became necessary. The important thing to remember is that even though there have not been any criminal charges filed yet in the state of Utah against an individual or public body for violating the Open and Public Meetings Act, there is the potential to be charged with a Class B misdemeanor. I believe this is a message from the Utah State Legislature that they do want to take seriously that the state's business be conducted in public rather than behind closed doors. So with that, I would thank you for your attention today and ask if any of you have any questions about the Open and Public Meeting Act, but please do not feel obligated to ask a question, as I likely will be back next year to review these concepts again. So are there any questions that you may have? Yes, Kumar.
My question relates to, are there any punitive damages that can be claimed as a result of not faithfully following the compliance?
No. The Act provides two primary different avenues of relief. One is the Class B misdemeanor or criminal charges against the body or individual members that violate the Open and Public Meeting Act. The other one is one that actually has been acted upon by Utah courts. And that is what they will do is, if the act has not been filed, if there's not been proper notice, if the agenda was not properly documented, et cetera, what the court will do is set aside the decision and will force the public body to go back and to redo or do over again and discuss it again, to review it again, to give everyone an opportunity to provide their input and then make a decision at that point. So the primary remedy that has been enforced on multiple occasions in the state is for the entire body to redo the work that has been done.
Thank you.
Good question. Thank you. Any other questions? Okay. Well, thank you very much for your service. And Noon, I'll turn it back over to you.
Thank you very much, Tony. With that, we are moving on to the next agenda item is the sickle cell disease presentation by the DRC.
All right, thank you, Noon. Good morning, everyone. Hopefully you can see the slides. Today, I will discuss gaps in sickle cell disease care for patients in Utah based on healthcare professional interviews and comparison with existing sickle cell disease programs in other states. This presentation complements the July presentation on potential barriers to medication therapy. Sickle cell disease, abbreviated SCD, is gaining recognition as a pressing health concern at the national and state level due to unmet patient needs, potentially due to healthcare inequities. For example, despite SCD having a higher prevalence in the US compared to cystic fibrosis or hemophilia, individuals with SCD who are predominantly of African American or Hispanic heritage experience less access to specialty care. In early 2023, Utah House Bill 487 was signed into law. The goal of this law is to develop recommendations for improving all aspects of SCD management, including the screening, surveillance, monitoring, diagnosis, and treatment. The exact SCD prevalence in the US is unknown because no data registry encompassing all 50 states exists. Utah does not currently have an SCD data registry. According to data from the National Newborn Screening Information System from 2005 to 2007 and the 2008 US Census, individuals living with SCD are concentrated in the southern and eastern US, with the highest density in Florida and New York. Although this data is older, it provides the last estimated SCD prevalence in Utah, which was estimated to be 82. Although a Utah SCD data registry currently does not exist, a rough estimate of the state's SCD prevalence can be independently derived using the CDC's reported prevalence rates in African American and Hispanic peoples and the 2022 U.S. Census Bureau data for Utah. Considering this, about 148 African American and 31 Hispanic peoples may have SCD in Utah. Nonetheless, Utah may have a lower SCD prevalence or SCD population than this rough estimate, given that patients may move out of Utah to mitigate the increased risk of experiencing symptom exacerbations, primarily vaso-occlusive crisis, at higher elevations. Notably, newborn screening for SCD is universally conducted across all 50 states, including Utah, and may aid in determining the state SCD prevalence. Over the past several years, the positive screenings for SCD are extremely low, especially compared to other states. The CDC manages the Sickle Cell Data Collection Program, which gathers state-level multi-source health information on individuals with SCD to analyze the demography and geography of the patient population to ascertain the long-term treatment, diagnosis, and accessibility patterns of affected individuals within the U.S. Currently, there are 11 participating states in this program, representing only about 36% of the American population with SCD. Utah is not among the participating SCDC states and does not currently have an SCD surveillance system. This table shows a simplified overview of the framework for implementing a statewide SCD surveillance system as developed by the CDC in collaboration with participating SCDC states. To gain insight into the clinical practice of managing SCD within Utah, we interviewed healthcare professionals affiliated with the hematology clinic at University of Utah Sugar House Health Center or Utah Center for Bleeding and Clotting Disorders at Intermountain Primary Children's Hospital. Approximately 45 pediatric patients with SCD are currently being treated at Primary Children's Hospital, and there have been around 3 positive screens for SCD in the past year at this institution. In the adult setting, there are about 20 patients with SCD currently being treated at University of Utah Sugar House Health Center Hematology Clinic. Note that not all patients who transition from pediatric care at Primary Children's Hospital are able to be seen at University of Utah Sugar House Health Center for adult care due to payer-driven restrictions. Hematology personnel at Primary Children's Hospital estimate that approximately 5 to 10 patients in the past year have been referred to other organizations within the state, and very few, if any, have directly transitioned to a sickle cell treatment center out of state. This slide lists the main barriers to SCD care in Utah per healthcare professional interviews. No formal SCD pediatric to adult transition of care program exists for patients with SCD at an institutional or state level. This is a critical area of concern because morbidity and mortality rates escalate for patients in the transition age group, resulting in higher utilization of acute care services and poorer health outcomes. Currently, Primary Children's Hospital and University of Utah Sugar House Health Center do not have a dedicated infusion center for severe sickle cell pain management. Therefore, patients are sent to the emergency department or ED for pain management. Acute pain management in the ED setting presents several potential barriers to care, including restricted access to opioids, treatment delays, and racial discrimination as a result of provider biases. Additionally, because the healthcare system is not integrated, allowing for an exchange of information across services, it is difficult for ED providers and hematologists to provide care for patients in these scenarios. Currently in Utah, resources and support for patients with SCD and their families are very limited. We are aware of only the 2 specialty centers for SCD, University of Utah Sugar House Health Center for adults and Primary Children's Hospital for pediatric patients. Thus, patients, especially those who are located outside of Salt Lake City, may seek care at non-specialized centers, which may not have the resources and/or clinical expertise required to manage patients with SCD. This slide outlines the 6 core elements of healthcare transition from GOT transition for a structured transition process from pediatric to adult care. Notably, the 6 core elements for healthcare transition remain consistent across settings, but the approach can be tailored to various practice settings and subspecialties. Of note, some SCD centers in other states provide programs dedicated to helping pediatric patients transition to adult services to maximize continuity of care and to help overcome transition-related barriers. To supplement the information obtained in the interviews about potential barriers to SCD care, we also reviewed more generalized barriers identified in published literature. Barriers to care identified from interviews were generally consistent with the barriers identified in the published literature, albeit published literature provided additional insight on patient perceptions regarding SCD care. Patient-reported potential barriers to care included inadequate insurance coverage, transportation issues, poor care coordination, difficulties finding a knowledgeable provider and treating SCD or locating community support groups, and provider mistrust. Provider-reported potential barriers to care included lack of necessary knowledge and unfamiliarity with SCD treatment recommendations, especially in the ED setting for managing acute pain, fear of prescribing opioids as pain management for SCD, and unawareness of patients' perceptions regarding stigmatization for requiring opioids. A survey of U.S. healthcare providers in non-emergency care found that hematologists and SCD specialists were significantly more comfortable prescribing opioids for patients with SCD than non-specialized providers, and overall, most felt comfortable managing SCD-related acute pain. Barriers also exist that impact availability of SCD treatments. Adults of African heritage, who are most likely to have a compatible blood type match with SCD recipients, experience barriers to donating blood that could be used for chronic red cell transfusion, which is a guideline recommended treatment for stroke prevention in patients with SCD. Barriers to donating blood identified by adults of African heritage included lack of trust in the healthcare system, sociocultural beliefs, limited knowledge about the importance of blood compatibility for people with SCD, and deferral criteria related to low hemoglobin levels. Utah currently lacks any established programs for surveillance of SCD aside from universal newborn screening for sickle cell status. To help improve care to patients with SCD in Utah and in fulfillment of Utah House Bill 487's provisions, we propose several ideas for consideration based on the current gaps in the management of SCD. Consider developing a sickle cell task force consisting of, but not limited to, hematologists, someone with SCD, or a caregiver to a person with SCD, members of community-based organizations with experience in managing patients with SCD, and a healthcare institution representative to develop a statewide surveillance system. A statewide sickle cell registry for disease surveillance may be especially beneficial for monitoring patients during the transitioning period from pediatric to adult care, and may possibly help improve services at emergency room departments if providers have access to patient diagnosis in the registry. Also consider raising awareness of SCD in the state by developing a statewide public campaign to engage the community, healthcare providers, and other relevant entities about implementing healthcare provider educational sessions on best medical practices for patients with SCD. Additionally, recommendations for consideration include ensuring that infants with SCD identified by newborn screening have appropriate follow-up care coordination and are offered resources upon diagnosis. Upon understanding the prevalence of SCD in Utah and identifying the required resources to support a statewide approach to implementing the infrastructure needed for SCD programs and services, Utah may consider developing a strategic state plan that outlines the projected milestones over the next several years. In summary, according to literature, on a national level, comprehensive care for SCD has been inadequate and can be partially attributed to healthcare inequities. Thus, strategic policy interventions are warranted to address the unmet needs of the SCD patient population. There are several barriers to care for patients with SCD. Through interviews with SCD specialists in Utah, we are informed that the main barriers include a lack of an SCD pediatric to adult transition of care program, no SCD-specific acute pain management facility, and limited resources in few specialized SCD centers for adult care. Additionally, more generalized barriers to adequate SCD care reported in published literature include insurance coverage issues, disease or racial stigma, lack of provider expertise or knowledge, and negative provider or patient attitudes. Despite the historically small SCD population living in Utah, demographics continue to change, with Hispanic and Black populations expected to increase in the future. Therefore, infrastructure for SCD care will become increasingly necessary. Thank you for your time and attention, and please let me know if you have any questions.
Thank you, Dr. Lulo. Does the board have anything we'd like to discuss or question for Dr. Lulo? Yes, Dr. Hoffman.
Good morning, everyone. I have a question related to the collaboration of this reporter with the Office of Health Equity in the department that's responsible for implementation of that Senate bill around the registry. I was unaware that we were going to talk about this today, and it would have been good to have them here too. Do you know?
Yes, we do have
There's
an
been
office. Yeah, there is an officer from the Division of Public Health Equity. Her name is Anna Fondario. She's also on the call today.
Yeah, no, I'm thinking about the Office of Health Equity. Hi, Anna. I'm just trying to make sure our teams are all connected.
Yes, they are. I am working with Vaughn and Brittany.
Okay.
And so we've been coordinating internally, looking at the different data surveillance systems that we have. And then we're also coordinating with Medicaid. So we do have a group that meets regularly.
Perfect. Thank you.
Yes, Kuma.
Just a thought. So we talked about 60, 70, 80 cases that are known. Is there some estimate of how many we might be missing in Utah, or no estimate? Because on one end we say cases are going to increase. So I was just thinking at what rate we might expect, or something of that sort.
I can speak on behalf of what I am aware of. And as far as I am aware, we don't have an exact estimate yet on the number of individuals affected with SCD in Utah. It's something that I think we're currently working on. But I think it is something that we can expect that will increase over time just based on demographic changes within our state.
So you think maybe 10% a year, 5% a year, something like that?
I don't know. I can't
No,
definitively.
I'm not pinning you down. I'm just
Yeah,
curious.
I would imagine it would, the way things have been trending, it would be a smaller increase. It would probably modestly go up.
And what about others who live in Utah? It's like less than 1% or something.
I'm sorry, I don't think I understand your question.
There are other nationalities, other people,
Oh, yeah,
Asians and so on, you know.
yeah.
They don't have this problem, right? Or we don't know.
That I'm not 100% positive on. I know it is more predominant in African American and Hispanic peoples, not to say that it couldn't occur in somebody of another ethnicity or race.
Yeah. And I was see, because what I was thinking was there are a lot more marriages, you know, cross culture and so on and so forth. So can that, you know, be so-called transmitted or show up in other groups as well, you know?
Yeah, I think it's possible, but I think that would be really rare. Because it is a genetic,
Thank you.
yeah, you're welcome.
Dr. Weinstein, you have a question?
Thank you. First of all, I want to commend everybody and thank you for the work done on this. It is, I think, an important multidisciplinary effort. I'm particularly interested to know, because of the stigmatization and bias and the points raised in the presentation and also in the extensive report about barriers and some of the complexities around opioid therapy. I haven't had the opportunity to take care of these patients here in Utah, but I had a lot of experience in my early career in New York, and we know that these patients have acute pain, but some of them go on to have chronic pain. And I'm wondering if in the development of the program, you have some consultation for pain management, again, given the complexities around access and particularly with our dynamic rules and regulations about opioid therapy. I guess my main concern is, you know, for support to those frontline hematologists and pediatric SCD experts who may not be as comfortable with the chronic aspects. I know they have more comfort with acute pain management, giving short-term opioid therapy, but some of those chronic patients might pose more challenges. I think there was a question in there. Thank you.
That was a great point, Dr. Weinstein. Any other questions, comment? Okay. Yeah, so this is a presentation where the RC gave a recommendation to the report that we're going to give to the legislative. And I think that was a great addition to consider, Dr. Weinstein. If there's no other point of discussion on this topic, we can move on to the next item. It will be the Beyfortus. Second.
Do we need a motion? I'm sorry.
Oh, thank you for that. We don't need a motion for
okay.
this. Yep,
Thank you.
thank you. So this presentation is focused on the Beyfortus nirsevimab. For the Beyfortus is used for the respiratory syncytial virus, or RSV. By the definition of the FDA, RSV is a virus that causes acute respiratory infection in individuals of all age groups. While most infants and young children experience mild cold-like symptoms, some infants, especially with their first infections, develop lower respiratory tract disease, such as pneumonia and bronchiolitis. Is a swelling of the small airway passage in the lungs that often leads to the emergency department of physician office visit. Premature infants and those with chronic lung disease or prematurity or significant congenital heart disease are at highest risk for severe RSV disease. Approximately 1% to 3% of children under 12 months of age in the United States are hospitalized each year due to RSV, according to the American Academy of Pediatrics. In most parts of the U.S., RSV circulation is seasonal, typically starting during the fall and peaking in the winter. It is transmitted from person to person through close contact with someone who is infected. The Beyfortus is indicated to use for the prevention of RSV in neonates and infants born during or entering the first RSV season. It's also indicated for children up to 24 months of age who remain vulnerable to severe RSV disease through their second RSV season. For mechanism of action, it is a monoclonal antibody product that is a passive immunization. It was approved on July 17 of 2023 by the FDA through the fast track approval. The Beyfortus provide a long-lasting protection from RSV, with the protection expected to last at least 5 months. It's about the length of the typical RSV season. It has demonstrated reducing the risk of severe RSV disease by about 80%. For doses and administration, for neonate and infant who entering their first RSV season, it's recommended to administer Beyfortus one prior to the start of the RSV season, giving by the IM injection per weight. So if the child is less than 5 kilograms, it will be 50 milligram one IM injection, and if it's 5 kilograms or greater, it will be 100 milligram by an IM injection. For children up to 24 months of age who entering the second RSV season, is only indicated for children who remain at increasing risk for severe RSV disease, be giving a single 200 milligram dose IM. The contraindication for the Beyfortus is in any children who has history of serious hypersensitivity reaction, including anaphylaxis or any of the Beyfortus excipient. They carry some warning and precautions of hypersensitivity, including anaphylaxis, only used in individual with clinical significant bleeding disorder is a warning to be used Beyfortus in an individual, sorry, I apologize for that, an individual with clinical significant bleeding disorder. As with any other IM injection, Beyfortus should be given with caution to infant and children with thrombocytopenia, any coagulation disorder, or any individual on anticoagulation therapy. Per the AAP recommendation, the AAP suggests following the CDC general best practice guideline for immunization, would recommend that the vaccination should be deferred for the person with moderate or severe acute illness. Similar to routine childhood vaccine, mild illness, which are without fever, should not be used for any reason to delay the administration of Beyfortus. There is some recommendation for the use of Beyfortus and Synagis. The American Academy of Pediatrics recommend the Beyfortus for all infants younger than 8 months born during or entering their first RSV season. They recommend it for infants and children aged 8 through 19 months who are at increasing risk of severe RSV disease entering their second RSV season. including those recommended by the AAP to receive Synagis. Those population included children with chronic lung disease or prematurity who require medical support, chronic defined by chronic corticosteroid therapy, diuretic therapy, or supplemental oxygen anytime during the 6-month period before the start of the second RSV season, including children who are severely immunocompromised, including children with cystic fibrosis who have manifestation of severe lung disease, including American Indian and Alaska Native children. The American and Indian and Alaska Native children is a newer group compared to the recommendation for Synagis. The AAP recommend children who have received Beyfortus should not receive Synagis for the same RSV season. They recommend that if the Beyfortus is not available or not feasible to administer, high-risk infants who are recommended to receive Synagis in the first or second year of life should receive Synagis until the Beyfortus become available. If Synagis were administered initially for the season and less than 5 doses were administered, the infant should receive 1 dose of Beyfortus. No further Synagis should be administered. If Synagis were administered in season 1 and the child is eligible for RSV prophylaxis in season 2, the child should receive Beyfortus in season 2 if available. If the Beyfortus is not available, Synagis should be administered as previously recommended. The ACIB also voted for inclusion of Beyfortus in the Vaccine for Children program. For the timing recommendation for the Beyfortus vaccination, the AAP and CDC recommended the provider should aim for the Beyfortus administration in the first week of life for infants born shortly before and during the RSV season based on geography. Administration can occur during the birth hospitalization or in the outpatient setting. Infant with prolonged birth hospitalization because of prematurity or other cause should receive Beyfortus shortly before or promptly after discharge. In most of the continental US, the CDC defines shortly before or during the season mean the administration of Beyfortus should be begin on October 1st and concluded on March 31st. The Beyfortus should be administered shortly before the start of the RSV season for infants younger than 8 months. Beyfortus should be administered shortly before the start of the RSV season for infants and children A through 19 months of age who are increasing risk as an increased risk for severe RSV disease. Beyfortus may be given to age-eligible infants and children who have not yet received a dose at any time during the season. The only children who met the high-risk criteria should receive more than 1 dose of Beyfortus, 1 dose in their first RSV season and 1 dose in their second RSV season. For healthy newborn at the end of RSV season who receive Beyfortus around the time of delivery should not receive a second dose entering their second season, even if they are less than 8 months of age. Also, a healthy infant born at the end of their first RSV season who did not receive the Beyfortus and are less than 8 months of age entering the second RSV season may receive 1 dose of Beyfortus. On the basis of pre-pandemic RSV infection pattern, Beyfortus may be administered in most of the continental US from October through the end of March. Because timing of the onset, peak, and decline of RSV activity may vary, provider can adjust administration schedule on the basis of local RSV activity in the community. At the Utah State Medicaid, we monitoring the RSV season rely on the announcement from the primary children when the RSV season starts. For the co-administration of Beyfortus with routine childhood vaccine, in accordance with the CDC general best practice for immunization, simultaneous administration of Beyfortus with age-appropriate vaccine is recommended. In clinical trial, when Beyfortus were administered with the routine childhood vaccine, the safety and reactogenicity profile of the concomitantly administered regimen was similar to the childhood vaccine administered alone, and the Beyfortus is not expected to interfere with the immune response to other vaccines. The Utah Medicaid policy, the Beyfortus is covered through the Vaccine for Children program. Utah Medicaid reimburse for the administration fee. when the claim is submitted correctly to our system. With that concluded my presentation. Any question or discussion from the board? Yes, Dr. Brinton.
I'm just really grateful that we'll be having this available. You're working with babies that were born just a tiny bit preterm, but otherwise had no issues, and seeing them have multiple complications from RSV, including needing ECMO, having strokes, being trach vent dependent afterward. This is such a wonderful cost savings approach. So I'm just very excited that we'll be able to have this available for these kids. And then just to clarify, this is just this is not the same as what the adults are getting, right? The adult RSV vaccine is more of a vaccine. It's not these monoclonal antibody things. Is that right?
Yeah, you're correct, Dr. Brinton. This is the monoclonal antibody one, and I believe the name for the adult is called Abrysvo. It's a different one. Yeah. Any other questions or comment? Dr. Smith.
So are we going to have prior authorization criteria to go through for this or not? And then my other question is this going to replace Synagis or be available along with Synagis?
Yes, we don't have the PA for this, as it is an open coverage for eligible patient. So the provider and the pharmacy who enroll in the VFC program can bill the supply through the VFC program, and we will reimburse for the administration fee. So there's no PA required on this pay for this. Also, it will be available together with the Synagis. The Synagis, however, the Synagis require PA. Thank you. Any other questions or comments? No, thank you. We do have a public comment from Sobi by Alexandra.
Hi, thank you. Can you hear me?
Yes. As a reminder, you will have 3 minutes in front of the board. Thank you.
Perfect. Good morning. My name is Alex Jarvis with Sobi Medical Affairs. Thank you for this opportunity to present information on Synagis, also known as palivizumab. Synagis is a humanized monoclonal antibody that is produced by recombinant DNA technology that exhibits both neutralizing and fusion inhibitory activity against RSV. Synagis was originally approved by the FDA in 1998 for the prevention of serious lower respiratory tract disease caused by RSV in children at highest risk of RSV disease. The safety and efficacy of Synagis were established in children with bronchopulmonary dysplasia, or BPD, that required medical treatment within the previous months and who are 24 months of age or younger at the beginning of RSV season. Infants with a history of premature birth, less than 35 weeks gestational age, and those who are 6 months of age or younger at the beginning of RSV season, as well as infants who had a diagnosis of hemodynamically significant congenital heart disease, who were 24 months of age or younger at the beginning of the season. As you may be aware, the American Academy of Pediatrics Committee on Infectious Diseases, the COID, published an updated guidance on palivizumab prophylaxis in high-risk infants and young children in July of 2014. This guidance asserted that preterm infants whose without chronic lung disease and born at 29 to 35 weeks gestation would not have a substantial clinical benefit from RSV prophylaxis, and thus removed the recommendations for palivizumab prophylaxis for this gestational age group. On June 26, 2023, the AAP COID group published their latest technical report on palivizumab prophylaxis in infants and young children at increased risk of hospitalization for RSV infection. This updated technical report reasserted their statements that palivizumab be recommended for those preterm infants who are born at less than 29 weeks gestational age, who are less than 12 months of age at the start of the RSV season. It also included preterm infants who develop chronic lung disease of prematurity, defined as gestational age less than 32 weeks and 0 days, with the requirement of greater than 21% oxygen for at least the first 28 days after birth, and those who continue to require medical support during the 6-month period before the start of the RSV season. Children, and then as well children with hemodynamically significant stage D during their first RSV season. On August 1st, 2023, there was an edition of AAP News that highlighted a letter written by the current AAP president, Sandy Chung, urging health officials to develop a comprehensive strategy as new RSV prevention modalities roll out. And this included the support of continued use of palivizumab for the prevention of RSV disease in those high-risk infants for this upcoming season. So based on today's testimony and previous testimonies, SOBI requests that Synagis is continued to be administered to infants who are at greatest risk for severe RSV disease and preserve physician choice for the coming RSV season. Thank you for your time.
Thank you. Any questions from the board for Alex? Okay. If not, that is all of the item on our agenda for the meeting today. The meeting will be in November 9th, next month. We will discuss the antidepressant insurance. Perfect. Thank you. Do I have a motion to adjourn the meeting? Thank you, Kuma. Do I have a motion? I have a second. Thank you, Dr. Weinstein. All in favor?
Aye.
Awesome.
Aye.
Great. Thank you very much for coming to our DUR today. See you all next month.
Stay well.